morning, everyone, and welcome to today's webinar hosted by PYA. Today, we are continuing our timely, tough, or tricky physician compensation and fair market value topics series with a presentation on fair market value specific to physician services in rural markets and call coverage compensation, including COVID implications. PYA is happy to present today's webinar on this important topic. You will have the opportunity to submit questions to today's presenters by typing a message into the question pane of the control panel. We'll collect these and address them by email after the webinar. All of our webinars are recorded and released with a copy of the slides after the event. With that, I would like to introduce Lyle Oelrich and Katie Taylor, Senior Manager at PYA, and Lyle is our principal.
Thank you, Laura, and a warm welcome to everyone this morning. My name is Lyle Oelrich, and we are thrilled to be here with you today in our fifth session to continue talking about key physician compensation and fair market value topics in 2022. As Laura mentioned, today we'll be discussing physician services in rural markets and call coverage compensation, including COVID-19 implications. In the event you missed our first four sessions, they're located on our website. At this point, I'll also ask the moderators to chat in a link to those webinars for your ease of reference. As a quick reminder, the discussion today will focus on general educational topics only, and nothing we talk about is intended to be definitive on any particular matter or to issue an opinion, which would be based on a specific set of facts and circumstances. I'm excited to be joined today by Katie Taylor, Senior Manager in our Compensation Valuation and Physician Services Department. Katie's located in our Knoxville office, has over 10 years of experience, and is a regular presenter and author on physician compensation and valuation topics. As for myself, I'm a principal in our Compensation Valuation and Physician Services Department, also located in our Knoxville office, have over 20 years of experience and led the development of PYA's compensation valuation practice. As an introduction for today, and hopefully to reintroduce some of you to this series, in January, we interviewed 30 physician compensation experts and asked them what they thought the top physician compensation and fair market value issues were going to be in 2022. This slide includes a list of those, and to date, we've discussed the 8 items that are in black text. And of course, today we'll move on to talk about physician services in rural markets and call coverage compensation, including COVID-19 implications. Also, we welcome your feedback on the top physician compensation and fair market value issues facing your organization. As you can see from this list, we're nearing the end, so send us your physician compensation issues and we'll see what we talk about next. So to begin our discussion today on rural markets and to lay the landscape for you, millions of Americans live in rural communities, and for the purposes of our discussion today, generally a rural area is defined as an area having less than 50,000 people living in it. And these rural communities don't have, or many of them don't have, essential access to healthcare services such as a hospital, an emergency room, or even a primary care clinic. As such, they can face really long delays in getting care. And for some of them, even if they have insurance to pay for health care, there may be nowhere in their community that they can use it. As PYA serves clients in all 50 states, we often find ourselves helping clients who are working to recruit physicians into rural markets. Because of this, we were not surprised to find this issue on our list of timely, tricky, or tough physician compensation issues this year. So for this section of the presentation, we'll cover the realities of rural medicine and the significant and difficult challenges hospitals and health systems in rural markets face when it comes to recruiting and retaining physicians. But before we focus on the fair market value and compensation related items, we wanted to provide some context surrounding rural markets. First and foremost, several rural hospitals have been forced to close over the last few years. Just by quick example, there have been 181 rural hospital closures since January of 2005. The top 3 states for these rural hospital closures include Texas with 24, Tennessee with 16, and North Carolina with 11. So when these hospitals close, all healthcare services in the community can disappear, creating a public health access issue at the very least. Specific to population loss, and this may be surprising to some of you all, many rural areas are actually experiencing a population loss. For example, in the recent 2020 census, it revealed that the rural population declined between 2010 and 2020. And while this loss was nominal, about 300,000 out of 46 million, it's the first decade-long rural population loss in history. And this population loss can challenge the need for providers and may give potentially interested candidates pause in coming into a community which is experiencing a population loss. Third, generally speaking, a need for healthcare providers exists in these rural markets. The rural market population represents 1/6 of the United States population, while the rural market physicians represent 1/10 of the United States population. This variance indicates a physician deficit related to providers serving these markets, which can also help support the need for an arrangement from a commercial reasonableness perspective when you may be working on such an analysis. Fourth, a bypass behavior exists in rural markets related to rural residents who opt to seek care in places other than their local hospital. This bypass behavior is related to deficits in care providers. Effectively, people seek care elsewhere because they can't find it in their rural market. So at times, this outmigration behavior can lead to a difficulty in recruiting and retaining providers in rural markets. As it relates to regulatory changes, they can often cause implications to hospital margins. One example relates to the expansion of state Medicaid. This expansion provides insurance for lower income adults, impacting the degree to which individuals seek care. Finally, a brief word on technology. Hospitals and health systems in rural markets may find it difficult to expend themselves financially for technology improvements. Some physicians, especially those coming out of residency, may be looking for this technology to continuing practicing advanced care. For all of these reasons and more, as well as just a quick aside, PYA has seen these issues as significant in helping this population, and we created what we have coined the PYA Center for Rural Health Advancement. The center helps rural healthcare providers transform their operations by delivering a full range of practical, rural-specific solutions focused on community engagement, clinical excellence, financial stability, and regulatory compliance. This center is headquartered out of our newest office in Helena, Montana, and certainly if you'd like more information, chat in now or just shoot us an email and we'll be happy to send that to you. So on this slide, we've included urban and rural compensation and work RVU productivity for 5 different specialties at the median to make some observations. As you can see from the data presented, overall, there is a compensation variance between the 2 demographic locations. However, this ultimately depends on the specialty considered. For example, general surgery, orthopedic surgery, and urology all have higher compensation amounts at the median in urban markets than rural markets. To me, this is interesting that these are all surgical-based specialties. Conversely, family medicine has a nominal variance between the two markets, while pediatrics compensation is higher in rural markets than urban markets. This may be driven in part by the shortage of pediatricians in rural markets and the need for these types of services regardless of location. Further, in each specialty listed except pediatrics, median work RVU productivity is higher in urban markets than rural markets. The location of a physician may affect productivity just as it does compensation. The high concentration of population in urbanized markets can push productivity to higher levels. However, physicians in rural areas may be less productive in terms of work RVU generation than physicians in urban areas, yet still require a similar level of compensation in some situations. This just goes to suggest to you, to me, and others that one factor alone does not determine a physician's level of compensation. Many other factors besides work RVUs, or frankly another metric of physician productivity, such as the number of failed recruitment attempts as well as the dollars associated with those offers in a rural market, may also be considered. MGMA's even studied the relationship between compensation and work RVUs, and for the most part, and again, at most, work RVUs generally constitute approximately 60% of the reason for a physician's compensation. That means that 40% of a physician's compensation is due to factors other than work RVUs. I think that's an interesting statistic as we think through the use of this information on a day-to-day basis in these types of analyses. As we move on to a comparison of compensation and professional collections at the median for all 5 specialties, professional collections are higher in urban areas than they are for rural areas. This could be due to a number of different reasons. However, it is likely in part due to the work RVU productivity levels of these specialties between the two markets, as we discussed on the prior slide. Also, work RVU productivity was higher for all 5 specialties in urban versus rural markets, except for pediatrics, whose work RVU productivity was fairly similar across the two markets. Finally, as we think about some other considerations for rural provider compensation, and there's absolutely no way that we can cover them today in the brief time that we have here today, we wanted to share a few other items with you. First, medically underserved areas, otherwise known as MUA, or health professional shortages, areas known as HPSAs. MUAs are areas or populations designated by the Health Resources and Services Administration, otherwise known as HRSA, as having too few primary care providers, high infant mortality, high poverty, or high elderly population. In contrast, HPSAs are designated as having shortages of primary medical care, dental or mental health care providers, and may be geographic, such as a county, might be population oriented, such as low income or Medicaid eligible, or even facility oriented, such as a federally qualified health center. And certainly understanding if the place of service that you're looking at is located in a MUA or HPSA can impact the fair market value of a provider and their respective compensation. Rural hospitals also struggle with inadequate reimbursement. For example, CMS determines hospital wage Medicare payments based on the differences in hospital wage levels. The hospital wage index is a ratio based on an area's average hourly wage to the national wage. Accordingly, rural hospitals have indicated that the wage index has inordinately led to rural hospitals getting lower Medicare reimbursement. And of course, such reimbursement levels can challenge what a rural hospital may be able to pay a provider, even if it's within fair market value. On the other side, there may be instances, for example, in HIPSAs or rural health clinics, where reimbursement may be paid at a premium for certain payers or based on the costs of that organization. Now, in my opinion, where physicians may be likely to fare better financially than those pursuing urban opportunities is in the realm of incentives. And these incentives offer ways outside of a physician's base salary to incentivize a physician to a rural market. You may be familiar with these, but some of them include things like education loan repayment, signing bonuses, relocation expenses, and others. But rural markets may have more motivation and eagerness to offer these types of incentives and potentially higher dollars related to these incentives. Finally, there can be large differences between rural and urban areas in terms of cost of living. For example, in rural areas, on average, housing is about 30% cheaper than in urban areas. And so these types of differentials also play a part in determining the compensation. Effectively, compensation that's paid may actually go further in terms of what may need to be paid by a provider on a day-to-day basis for their routine living expenses. So with that being said, I'm going to pause and pass the baton to Katie to talk a little bit about call coverage compensation.
Thank you, Lyle. I will take the baton to the finish line to continue with your metaphor there. So for the rest of the presentation, I'm going to be covering call coverage compensation, including COVID-19 implications. Compensating physicians for emergency department call coverage in some circumstances is now pretty commonplace in the healthcare industry. We're often engaged to help our clients determine fair market value for this call coverage compensation on a regular basis. However, some specialists are not willing to provide call coverage for a number of reasons. Some of those reasons include quality of life concerns, managed care pressures, increased risk of malpractice lawsuits by treating patients on an emergency basis, declining physician supply, physician burnout, and the required additional time away from a physician's practice of medicine. As a result, certain hospitals and health systems pay physicians to be on call. In fact, according to the Sullivan Cotter on-call survey, of those surveyed, 56% of their call coverage panels provide compensation for participating physicians, so over half. However, the increase in the number of call arrangements has also generated a heightened level of government scrutiny. The Stark Law and anti-kickback statutes require hospitals to follow certain guidelines and regulations to ensure call coverage compensation is structured appropriately. In fact, within advisory opinion number 12 through 15, the Office of the Inspector General actually stated, and I quote, "There is a substantial risk that improperly structured payments for on-call coverage could be used to disguise unlawful remuneration." So to help avoid the risk of violations of unlawful payments, hospitals turn to third-party healthcare consultants like PYA and legal counsel to provide guidance and ensure compliance. It is really important that call coverage arrangements be structured properly and that compensation is consistent with fair market value and commercial reasonableness to comply with these regulations. So there are various types of call coverage compensation that we wanted to talk about today. But an ongoing challenge for hospitals is ensuring continuous specialty coverage for emergency departments and inpatients that require urgent specialist consultation. Provider compensation for rendering such coverage is common and takes a variety of forms. So on this slide, we've got an overview of some of those common payment structures. And I'll go ahead and say this is not likely an all-inclusive list. There's probably a few other methodologies we haven't covered, but for time's sake, we've put the ones that we found to be most common on this slide. The first of which is the per diem or per shift compensation. This is a flat payment for each day or shift of call availability, regardless of the actual number of call events that are handled during the call period. So effectively, a physician could receive 20 calls during the shift or 1 call in the shift, and regardless of the volume of those calls, he or she would receive the same flat payment. The next is fee-for-service payments for care rendered to indigent or unfunded patients. This is a payment for any service that an on-call physician renders to a patient whose care is otherwise unreimbursed. For example, the hospital will assign a compensation rate for each type of service, which is identified using the corresponding Medicare physician fee schedule CPT code provided by the on-call physician to the unfunded patient. The third on this list is the per diem plus the fee-for-service payments to care for unfunded patients. So this relates to a flat payment for each day or shift of on-call availability plus a fee-for-service payment for any service that an on-call physician renders to a patient whose care is otherwise unreimbursed. Per diem per shift compensation is supplemented by fee-for-service payments for otherwise unfunded care that is rendered in response to a call event. The fee-for-service payments are generally structured as a percentage of the Medicare allowable rate for the services rendered and adjusted for the hospital's region. The activation payment is a fixed payment due for each instance when the on-call physician actually presents or comes on site to the hospital in response to an on-call event. The activation payment compensates for the burden of responding to on-call events and potentially for availability provided on an on-call coverage days, including those days when no call events actually occur. The per diem plus activation payment is a flat payment for each day or shift of on-call availability, plus a fixed payment due for each instance when the on-call physician comes on site to the hospital in response to the on-call event. Credit toward productivity compensation. This is when the hospital determines an appropriate amount by which to attribute productivity, for example, work RVUs in a work RVU physician productivity compensation model for call coverage services, and allows these work RVUs to be credited in the determination of the physician's productivity compensation. Lastly, uncompensated care coverage or professional liability insurance. The hospital will provide the on-call physicians with professional liability insurance or indemnification for their on-call services. So as you can see, there are lots of different methodologies for types of call coverage compensation. So on this slide, we have listed a non-all-inclusive list of factors which should be considered in the determination of fair market value for call coverage services. These are a list of items that we commonly ask our clients where we're being engaged to determine fair market value. Again, this is not an all-inclusive list, but this will give you, I think, an idea of the types of things to be aware of when you're evaluating your compensation arrangements. The first on this list is the intensity of the call coverage. Intensity examples include the number of calls received per day, the number of calls requiring emergency department visits, and the likelihood of performing surgery as a result of a receipt of a call. Burden of call coverage, and this is the number of physicians in the call coverage rotation. Burden will vary based upon the availability of providers. However, survey data does exist, which illustrates the average number of physicians in a specific type of call coverage panel. And using this data, you can evaluate whether the call coverage panel under consideration is actually more or less burdensome than the average. The time of the call coverage shift, so during or after business hours, weekday versus weekend, holiday, etc. Based on PYA experience and benchmark data reported by the Sullivan-Cotter on-call survey, at times there is a shift differential paid to physicians providing call coverage on evenings, weekends, and holidays, or times of the day that aren't as preferred by physicians in taking call. Specifically, at the mean, there is a 42%, 68%, and 81% premium above the regular hourly rate for providing evening, weekend, and holiday call coverage services, respectively. Specialty-specific factors and case acuity. So, for example, orthopedic surgery call coverage may be substantially more complex and/or burdensome than psychiatric call coverage, due in part to the types of illnesses orthopedic surgery patients present with at a hospital as compared to psychiatry patients. Types of call coverage, restricted or unrestricted. The more restrictive the requirements of call coverage, the higher one can expect the compensation to be. So for example, restricted call coverage usually necessitates that the physician stay on site. And even with unrestricted call coverage arrangements where the physician is not required to remain on site, the response time requirements can impact the compensation rates. And what I mean by that is oftentimes in the bylaws, it may dictate that the physician has to respond to a call event within 15 minutes. Sometimes we see 30 minutes, etc. So we take that into play as well. Primary, secondary, or concurrent call coverage. Primary call coverage indicates the physician is the first to respond. Secondary call coverage indicates the physician is a backup to the primary physician, and concurrent call coverage indicates the physician is providing call coverage to multiple facilities or specialties at the same time. So each of these scenarios requires a different level of commitment by the physician, which will ultimately come into the play of fair market value. Undesirable payer mix. Hospitals with a high volume of indigent patients or underinsured patients sometimes find it difficult to retain physicians for call coverage. This is because the likelihood of a malpractice lawsuit may be greater, the physician securing new patients is low, and sometimes the location of the hospitals is simply undesirable. So determining the appropriate structure and fair market value range of compensation for these arrangements requires an in-depth understanding of the unique dynamics and structure of each specific relationship, combined with a knowledge and comprehension of the characteristics surrounding the local marketplace. So in short, there's a lot to consider with these arrangements. So common mistakes related to call coverage compensation, and this, the first one on this list is paying the same rate as another local hospital ensures your rate is in line with fair market value. This may not always be the case for several reasons. The rate at the other hospital may not be consistent with fair market value. The value drivers could be substantially different between the hospitals, and there may be differences in community need for the call coverage services. Also, the required uncompensated call shifts may differ. So there's a lot to be considered when comparing two different call coverage arrangements. The second is solely relying on market compensation surveys detailing a range of rates for specialty call coverage. You've heard Lyle and I say this over and over again over the last 5 presentations. Survey data does not indicate fair market value. It's something that we consider, but is certainly not completely representative of fair market value. So all these surveys, although these surveys are useful in theory, they do include little to no specific information regarding the respondent's reimbursement risk and the burden and intensity of the call coverage they're taking. In addition, these surveys have minimal respondents and reflect only hospital to physician relationships. As these rates consist of data from parties with a referral relationship, they should be used cautiously. Lastly, paying a locum tenens rate for non-locum tenens coverage. Locum tenens coverage is typically the most expensive form of coverage, as it includes corporate overhead and a profit margin payable to the locum tenens provider. And it's designed to be used on an as-needed basis. So if a locum tenens rate is paid to a non-locum tenens provider, a non-locum tenens provider may be paid too much. Lastly, COVID-19 implications to call coverage. COVID-19, as we've said over and over again, has created significant disruption to all aspects of the U.S. health system, and the financial impact on hospitals and other providers has been absolutely staggering. Health systems are facing numerous financial and operational challenges, including volume recoverability and cost-cutting measures. So on this slide, we've highlighted some of the ways for hospitals and health systems to help mitigate the financial constraints caused by COVID-19. The first is concurrent call coverage. Allowing a physician to provide concurrent call coverage when the physician is qualified, of course, is one tactic being used by hospitals to help cope with a provider shortage. The second is excess call coverage. A hospital or health system may also consider paying a provider for this excess call coverage. The excess call coverage would be those additional shifts which exceed a minimum threshold per month. The hospital or health system would pay a fixed amount of compensation to the provider for any shifts he or she provides over the excess call coverage threshold. Next, reevaluation of intensity statistics. It may be important to reevaluate these intensity statistics because they impact fair market value for call coverage compensation. For example, is the provider receiving a significant increase in the number of calls per shift than he or she was when the call coverage compensation was determined? A discussion with the provider to reevaluate any changes in intensity would help address this issue. Balance with other forms of compensation. And consider other forms of compensation to supplement the call coverage compensation. One example of this is hazard pay. Hazard pay means additional pay for performing hazardous duties or work involving physical hardship. Work duty that causes extreme physical discomfort and distress, which is not adequately alleviated by protective devices, is deemed to impose a physical hardship. As such, the hospital is offering additional compensation, understanding the provider is dealing with a unique set of circumstances such as the COVID-19 pandemic. Transition to telehealth. While telehealth has been in place for decades, many providers have especially turned to it during COVID-19 as a way to replace face-to-face visits to ensure access to healthcare, treat non-COVID-19 patients, and help maintain cash flow. Many speculate that though sparked by the pandemic, telehealth will become the wave of the future and will remain in high demand even after the COVID-19 threat subsides. Telehealth offers the physician some flexibility as it eliminates the requirement to come on site. However, it still affords the hospital or health system with physician available on call. So we look forward to speaking with you again as more webinar series are scheduled and input is collected. So please continue to send Lyle and myself any recommendations for future presentations. And with that, I'll hand it back over to Laura Smith.
Thank you. And thanks to our presenters, Lyle and Katie. If you have any questions, their presentation and contact information will be emailed to you, along with a recording of today's webinar. Also, if PYA can provide assistance with audit, tax, compliance, valuation, or physician services, please call or email us. You may also visit our website at pyapc.com for more details about our specific areas of expertise or to subscribe to receive PYA insights. On behalf of PYA, thank you for joining us and have a great rest of your day.